Welcome to this presentation on COVID-19 and its impact on the cardiovascular system. I'm Dr. Shanthi Mendis. I'm a founder member of the Geneva Learning Foundation and a former senior advisor at the World Health Organization. COVID-19, as you know, it's a new disease. It emerged at the beginning of this year. And at the beginning, researchers and doctors thought that COVID-19 affects the respiratory system. Over the last 10 months, many studies have shown that COVID-19 also has an impact on the cardiovascular system. What do these new studies show? They show two things. People with cardiovascular diseases are more susceptible to COVID-19. People with hypertension, ischemic heart disease, and heart failure. They also show that when infected with COVID-19, they have a worse outcome. I will show you several studies which confirm this statement. A systematic review done recently looked at the prevalence of cardiovascular diseases in COVID-19 patients in hospital. A large number were studied, and 10 studies were included, and the results were pooled together. Hypertension was seen in 16%, and cardiovascular disease was seen in 12%. In another study, severely ill COVID-19 patients in intensive care units were looked at. And among these patients, nearly half of them had hypertension and around 20% had ischemic heart disease. So people with cardiovascular diseases are more susceptible to COVID-19. Infection reaches them and takes hold more easily. Studies have also shown worse outcomes, as I said. Let's look at a couple of these studies. A systematic review of 13 studies, including 3,000 odd patients, looked at patients with COVID-19 and found that hypertension increased the severity of illness and death from COVID-19 threefold, and that heart disease increased the severity of illness and death from COVID-19 fivefold. So the outcomes are worse. There was another study looking at deaths in 169 hospitals spread across Asia, Europe, and North America. 8,900 patients were looked at, and out of this sample, 515 died. And factors independently associated with an increased risk of death was found to be heart disease, coronary heart disease, heart failure, and arrhythmias. Based on this kind of evidence, a clinical risk score has been developed to predict the occurrence of critical illness in hospitalized patients with COVID-19. And this has been validated and published recently. Hypertension, cardiovascular disease, and diabetes are the top 3 comorbidities which identify patients with COVID-19 who may subsequently develop critical illness. Now let us look at some potential underlying mechanisms to explain the link between cardiovascular diseases and COVID-19. Pre-existing cardiovascular diseases may become unstable when you develop COVID-19 because infection-induced increase in metabolic demand might not match up to the reduced cardiac reserve. And this imbalance, coupled with the inflammatory response, can lead to plaque rupture, coronary spasm, cytokine storm, and hypoxic vascular injury. As you know, COVID-19 is spreading fast and affecting more and more people in all the countries of the world. 36 million people have been infected and more than 1 million have died. Cardiovascular diseases also affects billions of people, and every year 17.9 million deaths are attributable to cardiovascular disease. So COVID-19 and cardiovascular diseases together, they are a deadly cocktail. A deadly cocktail. Now let us look at why cardiovascular diseases are linked to COVID-19. There are two main reasons. Firstly, there are risk factors that link COVID-19 with cardiovascular diseases. These are shared risk factors: old age, male sex, and obesity. These are the three risk factors shared by both diseases. Second reason is that COVID-19 virus uses angiotensin converting enzyme 2 receptor to enter the cells of the host, the infected person. Let us look at this in more detail. The renin-angiotensin system, as you know, is an important part of the cardiovascular system, metabolism. Angiotensin is converted in this system to angiotensin 1 and angiotensin 2. ACE2, or the angiotensin converting enzyme 2, degrades angiotensin 1 and angiotensin 2 to other metabolites. What does the virus do? The virus uses ACE2 as a receptor to enter cells and dysregulates the renin-angiotensin system. There is another link. As you know, we use angiotensin converting enzyme inhibitors as medicines to treat cardiovascular diseases like hypertension, cardiac failure, ischemic heart disease. And in this renin-angiotensin system, ACE inhibitors act on angiotensin converting enzyme 1, and losartan, which is also a drug used in the treatment of patients with cardiovascular disease, is an angiotensin 2 receptor antagonist. And this medicine is also using a receptor and blocking it. So the important question is the use of angiotensin converting enzyme inhibitors like enalapril, ramipril, and angiotensin receptor blockers like losartan associated with greater susceptibility to COVID-19 and worse outcomes. So an important retrospective study has been done on patients with COVID-19. And in this study, published recently in JAMA, use of ACE inhibitors and angiotensin receptor blockers has not been shown to be significantly associated with either susceptibility to COVID-19 or mortality from COVID-19. This is a very important finding because this means that patients using angiotensin converting enzyme inhibitors and angiotensin receptor blockers should continue to use them as prescribed by their doctor. Recent studies have also shown that COVID-19 can directly damage the cardiovascular system. Arterial and venous thrombosis due to vascular injury and release of cytokines in COVID-19 patients sets the stage for acute coronary syndromes, ischemic stroke, venous thromboembolism, and myocardial injury manifested by raised circulating troponins. COVID-19 patients can also develop cardiac failure, new onset cardiac failure, and myopericarditis and cardiomyopathy have also been reported in patients with COVID-19. Cardiac arrhythmias can occur: atrial flutter, atrial fibrillation, and ventricular tachyarrhythmia. There are studies that show that excessive QT prolongation occurs in about 15% of patients who are on hydroxychloroquine azithromycin combination for treatment of COVID-19. So these are some of the cardiac manifestations. And of course, excessive QT prolongation can also lead to malignant ventricular arrhythmias, and there are case reports on this manifestation as well. Is there a long-term impact of COVID-19 on the cardiovascular system? This is an important question. There are two studies that indicate that this might be the case. Cardiovascular magnetic resonance imaging in patients recently recovered from COVID-19 has been done and recently published, and in 100 patients around the 71st day after diagnosis, this study found cardiac involvement in 78%, lower ejection fraction in some of them, and ongoing myocardial inflammation in 60%. There's another study that also shows important results. It is an autopsy study in COVID-19 cases. This autopsy study was done in patients after death, of course, and virus was present in the hearts of 61% of these patients who had died. And the virus was present in interstitial cells and macrophages infiltrating the myocardium. So obviously further research is needed to answer the question, could cardiovascular manifestations like heart failure, myocardial dysfunction develop after recovering from COVID-19? Only further research will give us the answer to this question. Now let us look at how COVID-19 impacts on the care of cardiovascular disease. Healthcare workers have to weigh the risk of admitting patients versus the risk of delaying treatment all the time because of stretched resources. Stretched resources result in curtailing of elective procedures, potentially subjecting patients to increased risk of complications sometimes. Importantly, delay in care of acute myocardial infarction and stroke has been reported, and this, as we know, can have adverse long-term consequences. So what can be done to strengthen heart and stroke care during the pandemic? There are several things that doctors can do. First, they can conduct consultations without a face-to-face visit whenever possible by looking at charts, monitoring data, and increasing the use of telehealth when facilities are available. 2, they need to develop and rehearse protocols for rapid diagnosis and triage to prevent delays in delivering acute cardiac and stroke care, and have clear instructions when to postpone non-urgent procedures. Third, unwarranted diagnostic tests have to be avoided. That will help to minimize unwarranted downstream diagnostic and therapeutic procedures, strain on healthcare resources, and exposure of caregivers to the added risk of COVID-19. Doctors must be aware of the potential cardiovascular side effects of various therapies used for the treatment of COVID-19. For example, cardiac arrhythmias in patients given hydroxychloroquine azithromycin combination. And lastly, health workers need to maintain a high degree of suspicion of COVID-19 when interacting with any patient, particularly those with cardiovascular diseases. They must take a travel history, a contact history, and take immediate steps to isolate patients if they have any symptoms suggestive of COVID-19, such as fever, cough, upper respiratory symptoms, and then carry out tests to confirm SARS-CoV-2 infection. Is there anything that cardiovascular disease patients can do to protect themselves from COVID-19? There are quite a few steps that they can take. They must adhere to the preventive public health measures that all must follow. Wear a mask when meeting people or going out. Maintain a physical distance from others of 6 feet. Avoid exposure to people as much as possible. Wash hands frequently and practice respiratory etiquette. Avoid touching the face and also surfaces like door handles, table surfaces, shelves when it is not necessary. They must continue to engage in regular physical activity, eat a healthy diet, low in salt, low in fat, and rich in fruits and vegetables, and make sure they don't put on weight. Because, as I mentioned, obesity is a risk factor for COVID-19. And if they are overweight, they must try by taking more physical activity to reduce weight. And they have to stop using tobacco and avoid harmful use of alcohol. It's also extremely important for them to keep a stock of prescribed medicines, to take them regularly as prescribed by the doctor, and control their blood pressure, blood glucose, blood lipids extra carefully. And if they develop emergency symptoms, for example, chest pain or symptoms suggestive of a stroke, they must immediately seek emergency care. Because delaying treatment, particularly for acute myocardial infarction and stroke, can lead to adverse consequences. So finally, if cardiovascular diseases are not prevented and remain undetected and uncontrolled, the virus finds it easy to infect people and keep spreading. Cardiovascular disease makes it more difficult to get the pandemic under control. Therefore, prevention and control of cardiovascular diseases should be an integral component of the response to the COVID-19 pandemic. Thank you for listening.